obesity care. So for much of my career, the focus has been on lose weight. Eat less, move more. Whereas now we understand that obesity is a chronic, relapsing disease. We understand the biology, that this is not just willpower. We also know that obesity leads to multiple other chronic diseases, over 200 obesity-related complications. So when we're treating somebody living with overweight or obesity, we're actually treating a multifactorial disease to improve their overall health. So let's start with the definition. What is obesity? So multiple professional organizations now recognize that obesity is a chronic, progressive, relapsing, and multifactorial disease, which is influenced by many factors. There isn't just one type of obesity, there are multiple types. And the predisposing factors include epigenetics, genetics, physiological, behavioral, social, cultural, and environmental. And as I've said already, obesity is the driving force behind many other non-communicable diseases. For example, type 2 diabetes, cardiovascular disease, fatty liver disease, and many types of cancers. So how does obesity, this excess of adiposity, drive all of these complications? So on the left-hand side of this slide, there is a depiction of adipocytes in a healthy individual. Now, adipocytes are highly biologically active, and they release a panoply of cytokines that then act throughout the body. As a person develops obesity, then the adipocytes increase in size and in number. And as they do this, the adipocytokines that they release change in profile. So we see an increase in TNF-alpha, we see an increase in IL-6, a reduction in adiponectin. So we end up with a systemic inflammation throughout the body, and this drives insulin resistance. And also we have an overspill of adipocytes and fat into other organs. So we have the deposition of ectopic fat and also visceral fat. And we know that visceral fat, so fat around the organs, is really linked as a risk factor for cardiometabolic disease. Also, the excess weight that comes from the fat impacts on a person in terms of impacting on their mechanical functioning. So this slide here shows you a meta-analysis of 14 different long-term studies. And the purple bars show us. But when these participants are followed up for 4 to 7 years, you can see from the red bars that the majority regain all of the weight that they have lost. And in some cases, they rebound and go higher than their starting weight. We now understand the biology that drives this. And I want you to think for a moment that all of the systems that regulate appetite developed in a very different environment. They developed an environment where food was scarce, and we have multiple systems that drive us to eat. And a diet is the modern day equivalent of a famine. And we've developed powerful biological mechanisms to prevent us from dying out during a famine. So as soon as a person reduces their energy intake, regardless of their levels of adipose tissue, the body responds to this. And it responds by increasing the appetite-stimulating hormone ghrelin, which drives hunger. There's also a reduction in the satiety hormones, PYY and GLP-1. The body also reduces its everything possible to make sure techniques like functional MRI, and we show people who are on a diet food cues, then their brain lights up like a Christmas tree and is really super responsive to high energy food cues. So what does that mean? So it means that the person experiences hunger. We've reduced energy expenditure and there's an increased interest in food. So while over time, then they regain their body, which has prevented us dying out as a species, which is maladapted for our current environment, where we're surrounded by energy-dense food and also by food cues. Now, there's another problem as well. So once a person develops obesity, their biology changes. So we see a change in the signals that come from the GI tract that tell a person's brain that they've eaten. So as they develop obesity, there's a PYY. There's also impaired signaling from fat stores to the brain. So we end up with leptin and also insulin resistance. And there are also changes in brain structure and how the brain responds to food cues. And when we use these special brain imaging techniques in people with obesity, again, the brain responds more acutely to food cues. So what this means is once a person's developed obesity, these change to continue gaining weight. And this is why we often see that with time, obesity and somebody's weight increases. So obesity is a chronic progressive disease. And what I'm showing you here is what happens when we try to reduce body weight. So regardless of whether this is with a lifestyle intervention, with pharmacotherapy or metabolic surgery, we have a weight loss phase. And then eventually a person's weight reaches a plateau. And then we have the weight maintenance phase. And during this time, we also often see as we age, we all tend to put on weight. And even if we don't put on weight, we tend to switch our body composition to have an increase in adiposity. Now, what happens if we stop the treatment? Well, what would happen if we had a person on a blood pressure tablet? They had controlled blood pressure. We stop the tablet, their blood pressure goes back up. And this is exactly what we see if we stop treatments for obesity. As soon as you stop the treatment, then weight is likely to come back because of the biology that drives a person's body weight back up to the highest weight that they've ever achieved. So how can we help patients to maintain weight loss? Because we know that actually in order to preserve the clinical benefits of weight loss, we need long-term weight maintenance. And for the long-term weight maintenance, we need a multifactorial approach. We need to think about the environment, practicing stimulus control. We need to use an interdisciplinary team. We need to set goals and acknowledge successes. And we need to really think about nutrition and physical activity, behavioral modification, and also pharmacological intervention to help people Now, let's move on to the role of Mounjaro in modern obesity care. So what is Mounjaro? Mounjaro is a single molecule designed to activate both the GIP and GLP-1 receptors. So it's acting on two of the body's own appetite-regulating systems throughout the body. It's based on native GIP, and it has similar receptor activity at the GIP receptor to the natural hormone, but slightly lower activity at the native GLP-1 hormone. It has a half-life of around 5 days, which means that we can give this once a week through a subcutaneous injection. And importantly, there is no dose adjustment required for patients with either renal or hepatic impairment. So I'm going to walk you through some of the key data from Mounjaro. This slide here is from SURMOUNT-1, which was the largest phase 3 trial in the registration program. And in this trial, participants who had a lifestyle and exercise intervention were randomized either to placebo, 5 milligrams, 10 milligrams, or 15 milligrams of Mounjaro. And as you can see, with the highest dose of 15 milligrams, at 72 weeks, we saw a 22.5% reduction in body weight. So SURMOUNT-1 was the first demonstration that we could actually achieve these levels of weight loss using an obesity management medication. What I'm going to show you now is a head-to-head study, which is a phase 3b study, comparing maximum tolerated dose of tirzepatide or semaglutide. So semaglutide, participants were on 1.7 or 2.4 milligrams, and for tirzepatide, participants were either taking 10 or 15 milligrams. And what you can see here is that both of these obesity management medications are leading to substantial double-digit weight loss. But if you look, you can see that tirzepatide, because it's acting on two hormone systems, is leading to, on average, a 21.6% decrease compared to 15.4% with semaglutide. But we are not treating obesity to lower body weight. We are treating obesity to reduce adiposity and to reduce cardiometabolic risk. So what I have here on this slide are some of the key cardiometabolic parameters which are assessed as key secondary outcomes. Now, just to mention here that Mounjaro is not approved for the treatment of blood pressure or lipids. It's approved for the treatment of obesity and overweight. But these data here show you the impact on key cardiometabolic risk factors, with a 10.2 millimeters of mercury reduction in systolic blood pressure, a reduction in diastolic blood pressure, a reduction in triglycerides, LDL and HDL. And just to orientate you, these are reductions with Mounjaro maximum tolerated dose compared to semaglutide maximum tolerated dose. So the greater reduction in body weight translates through into greater improvements in these cardiometabolic indices. So now I'm showing you what happens if we continue treatment, because this is a really critical question that your patients will have for you. They will say, well, if I lose the weight, is it going to be maintained in the long term? So the data here are from 176-week, the SURMOUNT-1 extension in people with pre-diabetes. And if you look at the slope of these curves, you can see that the weight loss is maintained over the 176 weeks. There is no evidence of an uptip or weight regain. So the average weight loss with 15 milligrams at 176 weeks is 22.9%.
Thank you, Rachel. I just would like to take this opportunity to learn from Katerina and Evelyn some perspective after and present this important data. So we've seen that weight loss triggers important counter-regulatory mechanisms, like ghrelin increases, and we have the suppression of some hormones, and also reduction in energy expenditure, and even altered brain response to food cue. So this is exactly the moment patients are succeeding in their treatment. But at certain point, they go to the clinic and they can ask you, doctor, when can I stop the medication? And I would like to learn from your experience, how do you manage the situation between the patient experience and perspective and the biology of the disease? Can you share with us, please? Evelyn.
I think it's very important that from the get-go, at the start of treatment, you already stress that this is going to be chronic treatment, so that you can discuss this up front, so that patients know that they engage in a long-term treatment. Second of all, what we need to realize is patients feel better because they're not as hungry anymore. They feel full quicker. They feel like that because the drug is working. So you can discuss that with a patient, and you can of course also discuss whether they are willing to have that effect reduced. Of course, our point of view is no, we should keep the treatment going, because as a chronic disease, obesity deserves chronic treatment.
Thank you, Catherine.
I also reinforce the concept of chronic disease and giving them examples of, as Rachel said, you wouldn't stop treatment for high blood pressure or high cholesterol. Many times, even with statins, patients come back to the follow-up visit with their labs and think, oh well, doctor, now my labs are normal, so I can stop the treatment. But that's not true. I tell them, well, these are normal because you are on the treatment. If you stop it, then the values would go up again, because unfortunately for chronic diseases, we haven't a cure yet.
Yes.
So we can just control them, and you need treatment to control them.
Is the biology active, right?
Yeah.
As we have for the chronic disease, we do have for obesity as well. So thank you very much. Let's now look at the data we have. The data show us what happened when patients stay on treatment versus patients who stop. So back to you, Rachel.
Thank you. So as Beatrice has said, the data showing now on the slide are the data from the SURMOUNT-4 study. And SURMOUNT-4 was designed to look at what happens if people stop treatment versus continue. So in this study, everybody had Mounjaro maximum tolerated dose to up to week 36. And as you can see, there was a 20.9% weight loss at that point. And then they were randomized to either continue on Mounjaro or switch to placebo. Those who continued on Mounjaro lost a further 6.7% of their body weight, leading to a 26% reduction over the 88-week period. But for those people who switched to placebo, then they regained their body weight. And if you look, they are still continuing to regain their body weight at the end of the treatment period, just really emphasizing the need for ongoing treatment in order to maintain the weight loss. So I now want to move on to talk about SURMOUNT-MAINTAIN, because the other question I'm sure you get asked by your patients is, can I reduce the dose? So in addition to, can I stop? Can I reduce the dose? MAINTAIN was set up to answer. So this shows you the study design. So again, participants in the initial study period had maximum tolerated dose of Mounjaro. They were then at week 60 randomized to either continue with maximum tolerated dose Mounjaro, switch to 5 milligrams of Mounjaro, or switch to placebo. And there's a really important point with this trial, because we realized that we cannot let participants regain all of the weight that they've lost. So there was a rescue built into this, so that after 24 weeks after the second randomization, if they had regained 50% of the weight loss, then we restarted Mounjaro to prevent them regaining all of their weight. And the primary outcome is the percent change in body weight between week 0 and week 112. So let me walk you through the data here. So for those who continued on Mounjaro, this is the purple line, then there was 22.4% reduction in body weight. For those who switched to 5 milligrams of Mounjaro, you can see that they regained weight, but their total weight loss was 17.0% at 112 weeks. But for the placebo group, then you can see that they really were regaining weight until we could rescue them. And that's why you see the plateau, because a high percentage of people in the placebo group and also some in the 5 milligram group receive rescue treatment to prevent continual increase in their body weight. So this slide is probably one of the most important to think about. So what is the percentage of body weight maintained if we switch to those different 3 options? So as you can see, with continued Mounjaro, then 100% of the body weight was maintained. For those that switched to 5 milligrams, then 70% of the weight loss was maintained. But for those who switched to placebo, bearing in mind we rescued many of these participants, 44% of the initial weight loss was maintained. But again, what about the cardiometabolic parameters? What happens to things like waist circumference, which is so important in terms of visceral adiposity? So with MTD Mounjaro, 20 centimeters, those that reduced to 5 milligrams, 16 centimeters, and those that switched to placebo, 8.4 centimeters in waist circumference. So that's a big difference between staying on maximum tolerated dose, the 5 milligram dose, and then switching to placebo. And we see a similar picture across HbA1c, systolic blood pressure, and diastolic blood pressure. This really shows that it's the reduction in weight and adiposity that is driving these cardiometabolic benefits. And if a patient stops or reduces their treatment, then this impacts on the cardiometabolic benefit that we are seeing. So I just want to go through some of the adverse events, because it's really important when you start a patient on treatment that they're going to say, well, what are the side effects, doctors? And I'm starting with the surmount maintain, because this makes a really important point. So the first column on here is when they're in the initial 0 to 60 weeks. And if you look at nausea here, it's 35%. But when they're in the continuing phase, so the people staying on maximum tolerated dose, you can see the nausea is reduced to 8%. And we see this with all of the GI side effects, that these are greatest during the dose escalation phase, but once a patient has reached a steady dose, then these GI side effects reduce. And if we look, we see similar issues with surmount 1, with nausea, diarrhea, constipation, dyspepsia being the most common side effects. But again, these are during the dose escalation. But if we look at treatment discontinuations, then these are relatively low, with up to 8% in the highest dose, 15 milligram dose. And then if we look at the 3-year study, again, we see a similar picture with GI side effects. But again, these decrease over time. And if we look at the adverse reactions in surmount 5, this is comparing Mounjaro with semaglutide. Again, we see side effects that we attribute to the GLP-1 class. And then finally, in surmount 4, which is where we withdrew the treatment, again, we see similar side effects. So how do you explain these to your patients, and what can you do to mitigate against these side effects? Number one is it's really important to explain that these GI side effects are common. But there are things that patients can do to reduce these side effects. For example, eat smaller meals. Suggest that they split their 3 daily meals into 4 or even more smaller meals. And that they also really listen to their body. That they stop eating when they feel full. And this is a really important point, because many people eat in the absence of hunger and eat through satiety. So actually telling them to listen to their body and stop when they start to feel full. Other tips that can really help is to avoid fatty foods. Fatty foods, as you may remember from medical school, release cholecystokinin, which then causes more delay in gastric emptying. And also to stay away from spicy foods and try bland foods for a while. It's also important to make sure that they stay hydrated, because many people, when they have a reduction in appetite, also feel like drinking less liquid. And this can lead to low blood pressure, constipation. So really stress that they need to make sure that they drink plenty of water whilst they're taking these medications. So how to prescribe once weekly Mounjaro? So we start with 2.5 milligrams once weekly, and then after 4 weeks, we increase to 5 milligrams. And this is the first maintenance dose. Then you need, as a clinician with your patient, to titrate to the dose that your patient requires in terms of improving their health. And the maintenance doses are 10 milligrams and 15, with step-through doses of 7.5 and 12.5. But this gives you the ability to tailor the dose of Mounjaro in order to improve their cardiometabolic health, as each patient is an individual. And the speed of the dose titration, again, that will depend on the individual, but they need to stay on each of these doses for at least 4 weeks before escalating. So what are the key takeaways from this? Number one, obesity is a prevalent, complex, progressive and relapsing chronic disease. It's due to abnormal or excessive body fat that impairs health. The use of pharmacotherapy, in addition to lifestyle changes, may help patients achieve their weight management goals. In the SURMOUNT-1 3-year study, 22.9 average reduction in weight was seen out to 176 weeks, showing that this is a durable effect. And then if we look at SURMOUNT-5, we saw that Mounjaro MTD demonstrated superior reduction in body weight compared to semaglutide, with a mean reduction with a greater mean reduction in body weight seen with Mounjaro than with semaglutide, which is a really key message that participants who discontinued or were switched to placebo regained weight compared to those who stayed on Mounjaro, who had a 26% weight loss versus 9.5% in those who stopped taking Mounjaro. And finally, in SURMOUNT-MAINTAIN, we have shown that if people continue on maximum tolerated dose, then they maintain their initial body weight. Meaningful weight reduction and also cardiometabolic improvements, but these were reduced compared to maximum tolerated dose, but both of these were much better than the people who discontinued.
We will repeat the polling question and just see if you still think the same as you were thinking at the beginning of the presentation. So again, based on the SURMOUNT-MAINTAIN study, what percentage of initial body weight reduction was maintained and what was the impact on cardiometabolic parameter improvement? Improvements at week 112 in participants who continued Mounjaro at the maximum tolerated dose, 10 or 50 milligrams. Option A, 44.3% and cardiometabolic parameter improvement reduced. B, 7.5% and cardiometabolic parameter improvements sustained. C, 85% and cardiometabolic parameter improvement reduced. And D, 100% and cardiometabolic parameter improvements sustained. And with that, we are going to start our discussion, and we are receiving a lot of questions here. I will start with one. It's a little bit big, but I think that is worth starting with this one. So, tirzepatide's prescribing guidance supports individualization, starting with 2.5 milligrams and clinical goals. And here is the thing, because we tend to receive a lot of questions regarding clinical goals and targets and how to define this to each patient. So in practice, what clinical signals tell you a patient has reached their optimum maintenance dose? If there's a target or maximum tolerated dose, or are there patients for whom a lower maintenance dose is the right long-term strategy? Starting with you, Katerina, please.
So I think, as we have learned, it's not just a cosmetic treatment, it's not a weight loss treatment. We address several complications of obesity, including cardiometabolic complications and mechanical complications. So it really depends on what complications are associated with obesity in that specific patient, and this should guide our treatment. This should be our treatment goal. So if the complication is well controlled, then you would stay at that dose. Otherwise, you need to increase until the maximum tolerated dose and until you have that complication well controlled. Be it OSA or high blood pressure or glycometabolic parameters. So it's not just weight. We should also look at the complications that are associated with obesity.
Thank you, Evelyn, please.
Yes, I think everything starts with staging your obesity patient correctly. And staging is, of course, we're clinicians, so we're very bound to look at things like blood pressure, glycemia. But if you look at the guidelines, what EASO says, it's also about the functional and the mental domain. So discuss with your patient what his or her goals are. Because, for example, you might reach a good blood pressure, good glycemia at a dose of 5 milligrams. But the patient said, I used to run marathons and I would like to do that again. And at the current weight, I'm not there yet. So that functional issue is also important. So it's about staging your patient properly, discussing at this side of the table, the doctor's side of the table, this is where I would like to get, and also listening very carefully to what is important to my patient, what are his or her goals in this treatment trajectory.
Their feelings, right? How
Exactly.
they are feeling about and what kind of activities they could return to.
Because let's not forget that the data show improvement in in physical functioning. They show improvement in quality of life. And I think it's important that we have an eye for that as well. So in contrast to diabetes management, where everything is a number, HbA1c below 7, blood pressure below that, LDL below that, treatment goals in obesity are much more diverse.
If I might add something, this is also very important for motivating the patient. Because you should, leverage those things that are most important to the patient in order to,
Rachel, please.
I agree with everything that's been said, and it's moving it from weight loss to health gain. I mean, the problem at the moment is many patients start on these treatments and stop because they're just focused on the numbers on the scale. And doing what you were doing, which is moving it away from the scale to what matters to them, what I would call non-scale victories, is how we get patients to stay on these treatments for the long term. And they're only going to have the health benefits if they stay on in the long term and don't do 6 months and stop.
And probably this is the reason that we named as complex the disease as well, because we do not have a specific target yet, right? Okay, thank you. So this is a question from China. What are the key parameters that should be monitored during Mounjaro long-term treatment for weight management? Would like to start this, Rachel, please.
So again, I would monitor in maintenance what I was doing in weight loss. So basically making sure, looking at all of their cardiometabolic risk factors, because during the weight maintenance, you may need to change the dose. Weight maintenance doesn't mean that you're just going to stay on a dose if they're not at the MTD. So you may, during the weight maintenance phase, depending on what's happening to your patient, you may need to modulate the dose and also potentially in the future even add in other treatments. So I think we're going to get to learn a lot about weight maintenance because we've never really focused on it before. So I think we need to be humble about thinking about weight maintenance because we've got a lot to learn as to how we're going to do this and how we're going to keep patients on therapy without them wanting to stop because they will want to stop.
Thank you. Evelyn, please.
Yes, I completely agree. It's how you stage your patient. Those are the things you follow up. Basic things, blood pressure. Of course, there's weight, but let's also look at body composition. If you have the opportunity in your clinic, in your practice, to follow body composition, please do, because we want the adiposity to be reduced. That's a different thing than weight being reduced. And again, functionality, because if weight goes down, but functionality goes up, even if there is some lean mass loss, there's improvement for the patient. And talk to them about how they eat. Do they get your dietitian continuously involved, get your physical therapist continuously involved, because you want them to be living healthily while using the drug.
Katerina.
Yeah, I completely agree, especially on this nutrition part, because people, of course, eat less because that's the mechanism of action of these drugs. And so we need to make sure that the quality of what they eat is very good in order to preserve lean mass, in order not to develop nutritional deficiencies. So that's very important. And also, of course, the cardiometabolic risk factors, all the parameters and how they feel. So there are not specific, blood works for monitoring safety that you should monitor long term. I think, it really depends on the individual patient, but there are some pillars like nutrition, body composition,
To disciplinary approach.
Yeah.
Yes.
Yes, and also anticipate issues. If you feel like nutrition might be a challenge, think about multivitamin pills, think about protein powder. So support your patient in order to prevent problems in the future. There's still questions, for example, what does it do in bone mass? So follow the guideline. A postmenopausal woman should be on vitamin D and calcium supplementation. So, remain that, keep that broad way of holistic view at your patient.
Can I add an additional point? The other thing is when patients reach their plateau, then often they think the medicine's not working. And also at that stage, then they can eat a bit more, and they're often really scared that I'm going to put the weight back on. So really helping them psychologically through that. This is what we anticipate, otherwise you'll just continue losing weight and disappear. It doesn't mean that you're going to suddenly regain all the weight. This is what we anticipate, that you've reached this plateau and the medicines are still working, and then we can show them some L4 to say, well, this is what would happen if you stop. So I think that's one of the hardest phases for patients, because they're obviously, many are still paying for the medication, but they're not seeing any ongoing weight loss. So really managing their psychology during that phase is really important.
Setting realistic goals is very important. Because, some people expect to lose, to go back to their weight when they were in their 20s. That's very hard.
And to compare with other patients.
Yeah, with other people. Yeah, my cousin lost 15 kilograms. Yes. My, husband lost more. So it's,
And that's interesting how the history has been written. So we were talking a couple of years ago to start the treatment that obesity has, a treatment that we have to manage this properly. And now we are moving forward about maintenance and how to tackle the situation about plateau, which is important, is a burden for the patient and for the physician. Okay, so moving on, why is it so common for patients to regain weight after the initial loss when stopping medication, and even when they are really motivated and doing everything right from a lifestyle perspective?
Because it's not just a matter of motivation, and if you stop the drug, then the neurobiology of obesity takes over. It's been estimated that for each kilogram of weight loss, hunger increases by 95 calories. So people feel, more hunger. They feel more hungry. They need to eat. And that's the main driver for weight regain. And this needs to be explained very clearly to people. And it's relieving sometimes for people because, they have been blamed because of their weight, and there is a lot of stigmatization still even among healthcare professionals. So they feel, it's just a matter of willpower because they have been taught so, but that's completely wrong. And when they learn that that's a disease and it's not their fault, that's very important and very motivating and very relieving for some of them.
Yeah, Evelyn, please.
It's basically, it's biology. That's why the weight goes back up again. It's like when you use an ACE inhibitor and you stop it. The RAS system kicks back in and blood pressure goes up again. We're not confused when that happens. It's the same thing with obesity medication. It's biology. That's why it works when you use it. So if you go back to, that's a lot of times, it's also in the mind of patients. If I only try enough, if I only try hard enough, I should be able to. And then I say, no, this is not about your character. It's not about perseverance. It's not about being a good girl or a strong man. It's not about that. It's about biology. And this drug is helping you. It's like a cane you can lean on. I had one of my patients describing it. I thought it was beautiful. She said, my husband has a very bad knee and he wears this brace all the time. And everybody accepts that. He has a bad knee, he wears a brace. And she says, I have obesity and this drug is the cane I lean on. It's my brace that I use to support myself.
Yeah, that's nice.
I think explaining that people will regain the weight to healthcare professionals, policymakers, is really important, because I think the biggest misinformation out there is that this is like a course of treatment, and then if the person tries hard enough, that they'll be able to maintain the weight loss. And I hear that so many times, and it's so completely wrong. So the examples you've both given, we wouldn't do it in any other chronic disease. And we need to make this the norm for obesity, that this is a chronic disease that requires chronic treatment. And if you start, you're looking at lifelong.
Shifting the narrative.
Absolutely.
Okay, so we are receiving a lot of compliments about the discussion, and the next question he started that he really enjoyed the talk. Can you explain a bit more about what changes in the body after weight loss? A lot of my patients think regain is just willpower, and I want a better way to explain to my patients that it isn't. I think that we are discussing this. If you could like summarize in a very easy way how to address this to your patients, starting with you, Evelyn, how to explain them that it's not a matter of willpower.
What I personally use is I use slide decks in my consultation. And I use, of course, layman's terms, but I use the slide decks to explain to people that things within the body change, because the sentence I always tend to use is, we were built for survival. That's what we are built for. That's what our biology does. It protects us against starvation. And that is not switched off because it's 2026. It's still there. So it's about, well, educating your patients about the biology, making them understand why this drug that changes their biology is an asset and not something that is a temporary fix.
Okay.
I also explain the biology, and it's like an elastic band. We'll go back to the original weight, to the original position. So it's like the body defends its weight. It perceives calorie restriction as a threat. And it's like when you're driving, it tends to conserve energy. So you would not accelerate, while you're running out of gas. You don't know where the next gas station is. And so you slow down and tend to save as much energy as you can, and your hunger for gas. So it's the same thing that happens when the body is on calorie restriction. It tends to save, conserve energy, and it's hunger. So it's like when you're looking for gas because otherwise you're gonna be stuck in the middle of nowhere with no gas.
Yeah, that's a good one. Would you like to add?
And I think it's also very important that we keep saying the same message, that this fight against obesity is not about willpower, it's not about character. So if you are struggling, if you are having issues, please come back. Because I always find in obesity clinics, sometimes people say, I was afraid to come back because I didn't lose what I hoped, or I gained back. And I said, no, I'm so glad you came, because that's why I'm here. So it's also creating for patients this very safe space where they can discuss their struggles and their fears and their hopes. And it's for us to respond with scientifically backed data to address those issues.
Rachel?
So I always used to explain the biology to my patients, and I'd then ask them what they'd understood, so that they could then go home and explain it to their loved ones. I'd say, explain back to me what I've explained to you. But I also agree with the fact that if patients aren't losing weight, often they won't come back. And we're showing them these data with these new medications, but not everybody responds. And I think that's the other thing, is that not everybody is going to achieve the average weight loss. And in those people who don't, then we mustn't make them feel like they failed. It's the medicine that fails them. And as we have more medicines, then we'll have more tools to help them. But if they feel like everybody else has lost weight with this medication and they haven't, then they won't come back. So I think that's the other important thing, that everybody's different, and we're there to support them, and it's the medicine failing them, not them failing the medicine.
I think this is linked to this question, Rachel, if you could address this. This question comes from Dr. McKemmer. Why does weight loss slow down or plateau after a period of using Mounjaro?
Because as you're losing weight, then you have compensatory changes in your body. And you have the medicine that's trying to lower body weight, and your body that's trying to get you to gain body weight. And when those two reach equilibrium, that's when you reach your plateau, which is, it's the body trying to stop you losing weight and the obesity management medication trying to reduce, and then you reach equilibrium. And that's different in each person.
Thank you. And there is a question from Dr. Hussein Morgan. How should I interpret the surmount-maintain data? Does this mean my patients need to stay on the dose that resulted in their initial weight loss? Start with you, Katerina.
I would say yes, ideally, because if that's the dose where you achieve the health goals you were aiming for, that's the dose. Of course, there might be situations where the patient can't be on that dose. Several reasons. One, of course, is cost. So going down to 5 milligrams is an option. We have seen that you maintain 70% of the lost weight, so of the weight loss. So that's an option that that could be done in clinical practice.
One of the best ways to go and to keep a healthier environment.
And not all patients need to go to the highest dose. It's really individualized. I mean, you can individualize treatment based on the health goals.
Evelyn, please.
Again, what we see is in part the dose-response relationship. Again, if you give someone an ACE inhibitor at 2.5 milligrams or 5 milligrams, you know the blood pressure is going to go lower with the 5 than with the 2.5. It's exactly the same with obesity management medication. The higher the dose, usually the bigger the effect. And again, this is lifelong treatment. And people change throughout their life. And there might be times, for example, they have serious trauma or they need to recover from surgery. And then in that phase, you might not want the appetite to be suppressed as dramatically as it was, for example, under 10 milligrams. And you might discuss then to temporarily lower the dose. Again, life is a dynamic thing. Conditions change, but you need to keep coaching your patient through those phases.
Okay, Rachel.
So the surmount-maintain show us that you go to the efficacy of the drug that you're taking. So the patient goes to the 5 milligram efficacy, which, as Evelyn said, that's what we do in every other, what we'd expect in every other disease area. It just is this view for obesity that you could reduce the dose. And through willpower, the patient might be able to maintain the body weight, but they can't. They go to the efficacy of the drug that they're taking at that time.
Okay, and then we have a question from Dr. Adele. When to know that patient should stay for another 4 weeks on the same current dose? Thanks. Rachel.
So it would depend on their appetite. If they basically had really reduced appetite and their weight loss was coming down, then you don't need to go up the dose, because you need to make sure that they're having adequate nutrition and they're not losing weight too quickly. And everybody's different. Many people can stay on one dose for months before they say, actually, I'm now getting the food noise back. So it comes down to asking the patient about their food noise, their appetite, their rate of weight loss, and then you can basically titrate the dose.
Yes, definitely. Would you like to comment on that, Evelyn?
Yeah, basically, I wanted to say the same thing. It's the balance between effectiveness and possible side effects. I could imagine that in someone that has severe obstructive sleep apnea, knee arthrosis, all those complications where we know that you need to aim for really like 25, even 30% weight loss if possible to get a significant reduction in the comorbidities. Then, of course, you could discuss immediately with your patient, we're really going to try to get you to the maximum dose, because that's where I, as a clinician, would like you to get your improvement of health, because again, it's about improving their health. Whereas if you have someone with other comorbidities or lesser comorbidities, you might be perfectly happy with lesser weight loss numbers. So again, balancing efficiency and side effects and goals.
Katerina, we have a question for you. If a patient is eager to that the goal has been reached, how would you approach this conversation?
Oh, again, I mean, I think it's easy. So I would explain that, now we have reached the goal, and then, the goal is also something that there is a lot of discussion about goals, but yes, but you are there because you are on the medication. So if you stop the medication, again, you would go, back to your original weight, or you will start regaining weight, most likely. So I will again reinforce the notions about the biology of obesity, and that even if the weight has plateaued, that means the medication is working, because as we have seen with dieting, almost everyone at some point goes back up to their initial weight, and so the medication helps them stay on that weight and maintaining the health goals.
Can I add
Yes,
to that?
yes.
I think in that conversation it's also important to go, what's the emotion behind it? Where does it come from? Let's not forget that a lot of our patients have internalized stigma, and they feel like they should be able to do it on their own, and they should be able to be strong enough. And that is an emotional discussion. So there's the rational part, explaining the biology, but also open up the discussion about what is the feeling behind the question, what's the emotion behind the question, how do you feel about yourself, where does the question come from?
And probably they are hiding from the family, from the friends, thinking that's something that they will treat immediately as an acute situation, and then it's going to stop.
That's why I very much agree with what Rachel said about explaining to the patient and make sure they understand, so that they can explain other people in their family.
Yes, to educate them, right? So another question from Dr. Kress from Germany. Does weight regain after initial weight loss appear to be more to subcutaneous fats, as this is the first compartment of fat overflow?
I don't think there's been enough studies to say exactly what the weight gain. I think that's one area we really need to look at.
Okay, and the next one about Surmount-Maintain. Surmount-Maintain show a clear dose-dependent effect on weight maintenance. Does this mean lower doses are a clinical compromise or a legitimate long-term strategy for the right patients? Rachel, please, would you like to start this?
The data show that if you lower the dose, you're going to have weight regain and your cardiometabolic indices are going to worsen. So it really depends on the patient. So if somebody has lower cardiometabolic risk, then potentially. So it's a balance between what the patient wants, their healthcare needs, and probably also cost.
Evelyn, Katerina, would you like to add something?
Yes, I completely agree. Again, this is where obesity sometimes differs from other types of chronic diseases, where goals are not simply numbers. That's why it's so fun and so nice to do obesity care, is that in every patient you need to look for what do you need.
Yeah, and also the response to treatment is very individual. So what we see from studies is an average, but then some people are super responders, some people would not respond that much. So it really depends on the person we have before us.
Okay, thank you very much. Unfortunately, I'll have to stop here. It's a tremendous pleasure for me to be here among the experts discussing this. So thank you very much for the outstanding faculty, for the presentation, insights, and the rich discussion. And thank you, our audience, for participating, for being here with us, commenting, sending your questions, and most importantly, to stay in the forefront of the transformation of obesity care. And with that, I would like to leave us with 3 take-home messages. So first, start earlier. So the sooner we engage patients, the more we support them, we help them in order not developing complications. So early start, early action makes difference. Second, stay in it. So weight regain is not a personal failure. It is the body doing exactly what biology tells it to do. And our job is to stay beside our patient with the right tools, the right follow-up, and most importantly, with a clear message that they are not alone. And third, about maintenance. We have to change how we think about maintenance. Starting treatment is a win, definitely. But keeping patients in treatment, this is the real hard work. And it is necessary, as it is for any other chronic disease. So let's act on it. because behind every missed diagnosis is a person waiting to be seen. So let's see them sooner and never look away. Thank you very much and see you next time.